Welcome.
Thank you very much. Good afternoon. I will try to go quickly and get everyone to their break. It's a short time period to talk about a pretty broad topic, so I'm going to move relatively quickly. Briefly, these are my disclosures, primarily trials, a couple of which will present some of the results here, and some consulting and investing companies that work for stroke technologies. So where are we currently, and how did we get here? As many of you may be aware, in 2013, there were 3 studies published simultaneously in New England Journal, which demonstrated a lack of improvement or benefit for performance of mechanical thrombectomy. They did not show any detrimental effects, but no benefit. However, these studies did not require confirmation of a large vessel occlusion before treatment. So in 2013, the opinion was there was overwhelming level 1 efficacy that thrombectomy was not beneficial for emergent large vessel stroke. This was despite an NINDS TPA trial, which showed positivity for a recanalization-based therapy, despite ECAS being positive, despite PROACT, which was an intra-arterial kinase therapy, and MELT, all of which demonstrated benefit in that direction. All used early targets, and all were compared to a placebo. So the concept of opening the vessel was clearly in benefit. Based on those studies, we knew that recanalization was better than no recanalization, and certainly within 4.5 hours and probably within 6 hours would result in clinical benefit. However, could we open up the blood vessels without harming patients? Based on those early studies in 2013, we knew that intra-arterial intervention was safe. In IMS3, in synthesis first, despite they withheld IVTPA, which was class 1 indicated, they still saw equal outcomes between both groups, no increase in death, no increase in symptomatic hemorrhage. IMS3 gave a reduced dose of IVTPA, which we know doesn't work as well in the bridging studies, and still, again, no increase in death and symptomatic ICH and essentially comparable outcomes. So despite the hullabaloo in newspaper covers that said we know recanalization, that we shouldn't be doing this, we knew recanalization was beneficial, we knew that TPA was beneficial, we had positive findings for intra-arterial lytic therapies, so that evidence really suggested intervention. However, people said it is not effective. In fact, the IMS3 investigators concluded that we should not treat eligible patients outside of any trial. And an editorial associated with them encouraged Medicare to halt reimbursement for patients that were not in trials. And in fact, in a PR spot, a famous stroke neurologist said, this is being done because it's very lucrative, and that's why doctors were doing it. Essentially, there was no role for this treatment. Fast forward to 2015, we now have, and this slide's out of date, we now have 9 prospective randomized trials that show clear, overwhelming benefit for the reopening of blood vessels in the brain and restoring stroke. This all started with Mr. Clean, which is about 2.5 years ago, was presented. And in this study, you'll see this is a modified Rankin assessment that shows a dramatic adjustment with improved outcomes, the darker colors on the left, in the intervention arm versus the control arm. Whether you dichotomized or did a shift, it didn't matter. If you dichotomized modified Rankin 0 to 1, 0 to 2, 0 to 3, all were significant, all showed about over 2-fold increase in good outcomes. Whether you looked at NIH stroke scale, whether you looked at Barthel index, whether you looked at every subgroup analysis that existed, every single one, whether significant or not, was in the direction of benefit for intervention. We performed a meta-analysis of all the randomized trials, including just Mr. Clean, as well as those lacking benefit trials that were completed, and they showed overwhelming evidence of benefit in this population, whether you controlled for presence of large vessel occlusion or not. But that meta-analysis was unnecessary because shortly thereafter, 7 subsequent trials came out. ESCAPE was the first, run out of Canada. Again, dramatic evidence. If you see all those white squares in the interventional arm, much more benefit with intervention, substantial improvements in mortality. When they say treatment there, they mean IVTPA, so this is whether the patient's got IVTPA or not, dramatic improvements in benefits. Again, every subgroup showed the direction of benefit towards intervention versus medical therapy. Extend-IA, a trial ran out of Australia, maybe one of the smallest randomized trials to be published in New England Journal. They had 79 patients, and 70 in the final analysis. Again, dramatic suggestion of improvement, no increased death or symptomatic hemorrhage. Swift Prime, which was the first trial to come out that was specific to a particular technology, the stent retriever, dramatic evidence of improvement across the entire analysis, whether you looked at dichotomized or shift, all secondary analyses in the direction of benefit towards intervention. Revascat, a population-based study that was also device-specific towards the solitaire stent retriever. This was run in Spain, and they went out to 8 hours. Again, huge trend towards benefit. It's a bit redundant that every study keeps showing the same thing. And then therapy, which was the only trial that evaluated aspiration thrombectomy, which was the one that I was PI of. Again, significant improvement because it was halted early. The primary outcome just missed, but secondary outcomes showed an odds ratio of about 2.3 and 2.4 with significant p-values, all pre-specified secondary outcomes towards benefit. So we now know without question opening up the blood vessel is critical. Where do we go from here? And the primary question that's driving decision-making and the academic circles around stroke currently is how do we get patients the treatments they need? There's a 74-year-old woman, no significant medical history, highly functioning in Midtown for a meeting, becomes aphasic and densely plegic on one side, and she went to what's now called Mount Sinai West, was called Mount Sinai Roosevelt. We have a model here where to some of our associated hospitals, we as the physicians actually will go there and perform the acute stroke intervention, even if we're not primarily there for elective cases. This was the clot pulled out of her head. She returned to completely normal. And in fact, it was Donna Shalala, prior Secretary of Education, head of the Clinton Foundation at that time. She had staffers in the room the next day. I'm not giving in HIPAA. This was a press release that she put out. What she highlights at the end, I was lucky to be in a great city with a first-class stroke program, enough to reverse my condition. That's the lesson for everyone. If you have symptoms, don't wait to get help. The key is how do we get patients these treatments right away? The reality is that most stroke patients in New York City and across the country, in fact, literature suggests under 10%, actually get to a place where they can receive this large vessel occlusion therapies. We need to figure out how to fix that. The reason is we have a very convoluted health system. We have extreme barriers to care for patients to get to the place, and our entire healthcare system has been set up to get IV-TPA, a medically pushed drug that can be done in almost any emergency room, to be the primary guider of where patients go. So we don't have pre-hospital triage for stroke, unlike in the cardiology world where patients with STEMIs are able to go directly to labs that can treat them, and patients are brought to the nearest stroke center, which may or may not be able to provide this therapy, and therefore the patients are being triaged towards a much less efficacious therapy, IV-TPA. And so this is really the focus of what we're trying to do in the modern era. Much like in the heart, time is brain. This is an amalgamation of many studies showing the decrement and good outcome with time. This is a group analysis plotting all of the trials that exist for thrombectomy and showing that the longer, just globally in that study, the longer it was till recanalization times, the worse the outcomes were in patients' results. And this was my favorite figure of 2016 from a paper. This shows if a patient has a large vessel occlusion, gets a CAT scan, and that CAT scan shows the aspects is good and that patient's brain is salvageable and we can help that patient. This is the brain death curve that happens after that. If you get that blood vessel opened in 90 minutes, your patient has over a 90% chance of being independent based on this analysis. If instead of 90 minutes you wait 180 minutes, your patient has about a 20% chance of becoming independent. So timeliness is absolutely crucial. So what do we need to do? We need to figure out the best way to get the right patients to the right place every single time. We need to get better methods to getting the arteries open, and we're doing studies to figure that out. And we need to extend the time window as best we can, whether with medications, with augmentative therapies, or peri-procedural management. What we're doing here at Mount Sinai is working to build a stroke emergency suite where we'll be able to directly treat patients much more along a cardiac cath fluid work model, instead of the intervention being housed in a basement in radiology that's a 40-minute walk and elevator ride from the emergency room. Will be co-localized and immediately able to provide treatment, minimizing delays in transport, a system that involves no bed transfers to both get the CTA and do the treatment, and develop a showcase center to evaluate these processes. This is what we're doing currently. Time is brain. The current standard target that gets discussed in Joint Commission and other things is 90 minutes, Brain Attack Coalition. In 2015 and actually in 2016, happened to be the exact same number. Our door to puncture time for stroke interventions was 58 minutes, which is somewhat laughable, I think, in cardiac circles, but we're getting there. But our goal is to change this, to get rid of all of these delays, bed transfers, and other slowdowns, and change the conversation to 15 minutes or less for puncture and then reperfusion. This way we'll save more lives. We'll combine this with prospective randomized trials that we're currently running here in concert with many other multi-center initiatives, and hopefully improve care. Thank you very much.